Good morning, and thank you for giving me the opportunity to participate in this high-class vascular carnival. To start my presentation with chronic SFA occlusion, whether to do drug-eluting stent or drug-coated balloon or what else. So to start with the guidelines, the European Society of Coronary, in collaboration with the European Society of Vascular Surgery, talking about the intermittent claudications, they give them the intractable claudications or life-threatening, life-limiting claudications. They can have an endovascular option. So what about the NICE guidelines? They offer angioplasty for treating people with intermittent claudications if it is life-limiting, and don't offer primary stent placement for treating people with intermittent claudications caused by 𝗷𝗏 disease except for complete occlusion. So what about the American guidelines? The American guidelines stated that revascularization with endovascular options is a reasonable treatment option for lifestyle limiting claudications. And the technique chosen is related to lesion characteristics and operator experience. So whether to choose drug-eluting stent or drug-coated balloon, a prospective randomized study published in JACC Cardiovascular Intervention in 2018, they concluded that patency was maintained longer with drug-coated balloon treatment than after conventional balloon angioplasty. Another study, a 5-year follow-up study of the Thunder trial, was published in Cardiovascular Intervention as well in 2015. They concluded that in 154 patients follow-up, the reduced target lesion revascularization rate following paclitaxel-coated balloon treatment was maintained over the 5-year follow-up period. A study published in Cardiology in 2014 called Combination of Rotational Atherectomy and Paclitaxel-Coated Angioplasty, they concluded that rotational atherectomy in combination with paclitaxel-coated angioplasty might be an effective method with a promising low rate of restenosis. So what is the expert opinion in such case? An intrinsic article published in Endovascular Today in 2014 asking for expert opinions. They concluded that lesion need preparation first with atherectomy device, then using drug-coated balloon after lesion preparation may improve patency, and using drug-coated drug-eluting stent is a bailout in case of dissections. In Circulation in 2011, about 470 patients randomized to drug-eluting stents or PTA and bare metal stent. They concluded that treatment with paclitaxel-eluting stent was associated with superior 12-month outcomes compared with PTA and provisional bare metal stent placement. Supporting to this was Mark Burkett in 2016. He published a very good commentary article in Circulation as well in cardiovascular medicine. His wrap-up was drug-eluting stent treatment rises above other options for most patients requiring SFA intervention, but there was a conflict of interest noted. And Lawrence Garcia was against that opinion, and he published in the same or commented in the same journal in 2016 that a leave nothing behind strategy performs well and in fact has the same degree in comparison with the stent trials regarding the patency. But again, there was a conflict of interest. Drug-eluting stents in the superficial femoral artery, the long and winding road by John Reid and Michael Hong, they stated that in Circulation in 2016, many questions remain unanswered. However, after a long and winding journey, we have strong evidence that drug-eluting stent improve outcomes in SFA. A meta-analysis of outcomes of endovascular treatment of infrapopliteal occlusive disease with drug-eluting stent in 2013 in Journal of Endovascular Therapy. They included 4 randomized clinical trials and 2 observational studies reporting on 544 patients. They stated in their conclusion that their analysis was demonstrated superior short-term results with drug-eluting stents compared with bare metal stents. And in another network meta-analysis of randomized controlled trials was published in the Journal of Vascular Surgery in 2017. They included a total of 33 studies, and the rank order from higher to lower patency, primary patency, in the multidimensional scaling was in favor of drug-eluting stents, then followed by bypass surgery. They concluded that drug-eluting stents has shown encouraging results in terms of primary patency for SFA, whereas bypass surgery still remains its rule as a principal intervention. In 𝗔𝗹𝗶𝗀𝗀 study, comparing 𝗔𝗹𝗶_PTX stent versus bypass surgery in 𝗓𝗏opopliteal lesion in 2020, a multi-center study in symptomatic task C and D 𝗓𝗏opopliteal lesions comparing endovascular PTX with bypass surgery using prosthetic graft. That was done between 2013 and 2017. The estimated 24 months primary patency was nearly the same between both groups, and the estimated 24 months freedom from target lesion with revascularization was in favor of PTX, Zölver stenting. They concluded that with non-inferior patency results for the PTX group, a lower complication rate and shorter procedures and hospital stays, paclitaxel eluting stents might become a recommended treatment for long-tasked C and D 𝗓𝗏opopliteal lesions. So to conclude, endovascular revascularization is a reasonable treatment option for patients with lifestyle-limiting claudication. The technique chosen is related to lesion characteristics and operator experience. Lesion preparation with atherectomy devices followed by drug-coated balloon is an optimistic option. Drug-eluting stent has comparable results to surgery regarding patency with even lesser complications and hospital stay. A head-to-head study to compare drug-eluting stent and drug-coated balloon is needed. The fast everyday improvement in medical technology is in favor of drug-eluting stent or any other endovascular techniques. Thank you.